Welcome back, everyone. Welcome, Dr. Eman. I would like to introduce our next speaker, Dr. Eman AlSalman. Dr. Eman, she is a dual board-certified family medicine specialist based in Bahrain. She's actively involved in initiatives to reform and improve healthcare practices at the primary healthcare centers in Bahrain. She has been a key member of the PHC Autonomy Project Management Office, focusing on enhancing healthcare delivery systems. Her avid interest in healthcare policymaking and research is matched by her dedication to improving patients and providing satisfaction within the healthcare system. Welcome, Dr. Eman. Please, you have the mic.
Thank you so much. I'm just going to be sharing my slides.
I think you should unmute, still mute your voice.
Can you hear me?
Still, we can't hear you yet.
We can hear you, Dr. Eman.
You can? Can you or you can't?
Yeah, no, we can hear you, doctor.
Okay.
Just
so
little louder is okay.
Okay, sure.
No, it's okay.
Okay, great. Let me just share my slides. So first of all, thank you for having me in this review course. My name is Eman AlSalman. I'm a family physician from Bahrain. And أول شيء السلام عليكم and Jum'ah Mubarakah. So I'll be presenting a practical guide to contraception in primary care. It's quite a heavy topic, so I'm going to try my very best to make it as concise as possible, as long as we just follow a given structure. So basically, this is the outline of my presentation today. I'm going to start with an introduction, then we're going to explore the different methods of contraceptions that are available and how to choose among them. And we're going to follow that with a couple of scenarios, and then we'll conclude our session. So first of all, as a healthcare provider, specifically family physicians and general practitioners, we have a very important role in educating and guiding our patients in family planning and contraception, because we need to have the knowledge to provide them with the information necessary to equip them to have to make a consent or let's say a well-informed decision. So we need to have some sort of knowledge of the full spectrum of contraceptive methods. Even if they are not available in our practice, that doesn't mean that we shouldn't offer it. So basically, you need to know every single type that is available in order for you to counsel the patient properly, and then they can make an informed decision that aligns with their medical needs and their personal needs. So this is a very, let's say, simplified version that I've created while I was a resident, and I still use it today in my clinical practice, because it's not only important for us to pass our exams or be able to answer questions on oral in our oral examinations, but we're going to have frequently patients visiting us in our clinics asking for contraception. So you need to offer them all the different options and discuss it. It can be overwhelming, but however, if you follow this guideline and group the contraceptive methods in these categories, then you can discuss with the patients the different methods, and hence they can basically make a choice. So broadly speaking, we can categorize them into natural methods, barrier methods, hormonal methods, and then surgical methods. And then there's the others. If we come to the natural methods, basically these are hormone-free. So we've got the fertility awareness methods, the withdrawal, the abstinence, and then you've got the barrier methods. These are whether male condoms or female condoms, spermicides, diaphragms, cervical caps, or sponge. And then you come for the hormonal methods. The hormonal methods are either the combination, which is estrogen and progesterone, either in the form of pills or the transdermal patches, or the vaginal ring, which is the Nova ring. And then you've got the progesterone only. So this is just progesterone without estrogen. It comes in the form of the pill, POP, progesterone only pill, or it can come as in the form of an injection, which is Depo-Provera, the implantable, which is the Implanon, and then you've got the intrauterine device or intrauterine delivery system, which is the Mirena. These are the hormonal aspects. So when you're grouping them, you're going to notice later on in the session, I will not be going into details, because once you group them, you know exactly who can benefit from them, what is the side effect, the mechanism of action, and the contraindication if you group them in such a way. And then you've got the surgical methods. The surgical methods, of course, these are done in secondary care, but like we are the first contact for patients seeking these forms of contraception. So therefore, we need to be aware about them and about details. Hence, we're touching on them, which is the vasectomy, male sterilization, and tubal ligation or tubal occlusion, which is female sterilization. And finally, the others, we're going to be talking about the copper intrauterine device, which is basically the non-hormonal intrauterine contraceptive device, and the emergency, the EPC or emergency postcoital contraception. So I'm just going to spend a bit more time here because, like, as I said, if you know that the outline, it will be easier to follow through during the subsequent slides. First of all, like when I've done this overview, this resembles the contraception options that are available for patients in Bahrain. I spoke to a couple of my colleagues in Kuwait, and they did mention that contraception is not available at the local health center in Kuwait, but this is not the case here in Bahrain. So we have some sort of contraception available, and you can see from the diagram, the icon when you have the tick, that's available, which is the combined oral contraceptive pill and the copper intrauterine device. And soon we will be having as well the Implanon added to the list. And then you've got the icon with the shopping bag. These are options that are available for the patient outside. So they basically, we can write it as a prescription. The patient can purchase it and bring it back where we can basically administer it or help them use it, except of course for the Mirena, that's not available yet. So basically they would have to go to secondary care to insert the Mirena because it's usually ultrasound guided. As for the X icon, these are options that are not available in Bahrain, namely the female condoms, the diaphragms, the cervical cap, and the sponge. So additionally, there's an important thing that I wanted to mention on this slide as well. As you can see here at the lower left corner, this is important for you to know, which is the time until effective. This is one of the key questions that keep on being repeated, not only on examinations, but even when the patients come and ask you. So basically, you need to tell them, in order for them to avoid pregnancy, they have to ensure that they follow the time frame. So if we were to insert the copper intrauterine device, this works instantly. The progesterone-only pill requires 48 hours, which is 2 days. And then all the rest of the methods, they require a week of correct use. So this is very important. And as you will see later, I'll be re-emphasizing this on the slides. But if you know it now, it will be easy. So copper instantly. Progesterone-only pill requires 48 hours, which is 2 days, whereas the rest of the methods requires at least 7 days, which is namely a combined oral contraceptive pill, the injection, the implant, and the Mirena, which is the hormonal intrauterine device. And since we're at this slide, the only contraceptive method that protects against STDs, which is sexually transmitted disease, are the condoms, whether male condoms or female condoms. All the rest do not offer any sort of protection against STDs. So with that in mind, we're just going to go quickly through these slides. So you know now, because we had that overview, think of that structure in your head. We're going to start with the left branch of the diagram, which is the fertility awareness method. Since it's natural, we call them the natural methods. There's no hormones involved. Since there's no hormones involved, that means that there are no side effects for the use of these methods. However, we have to be very cautious when we're counseling a patient regarding the fertility method awareness methods, because it requires proper explanation. So if you're not 100% sure how it should be done, you need to refer the patient to a specialist, or you need to basically educate yourself further. Second of all, it requires that the patient has a high level of commitment, because he will have to basically have a routine that has to be done every day of the month in order to identify where is the fertile window for her, and tries to avoid basically intercourse during that period, hence avoiding pregnancy. And this method is only suitable if a woman has a regular period, because it can take up to at least 6 menstrual cycles to know the fertile days. I know that there's a lot of things that would make it easy for the lady, which is using a mobile application to track her periods. That can be very useful. So she can log everything. She can basically bring it to the clinic, and then you can see where is that fertile window based on her log. So as I said, there's no side effects, and effectiveness depends on how well the method is being followed, and several other factors, even like, for example, things like stress, lack of sleep, shift work. If the woman has that, this is not a proper way for her, because we all know that cortisol increases, levels will cause menstrual irregularities. Hence, this is not a proper method for use. So the criteria for selection for this method is quite comprehensive. So as I mentioned, it involves tracking the menstrual cycle, logging it on a calendar. It requires daily measurements of physiological signs such as cervical mucus thickness, measuring her basal body temperature. Just before going out of bed, she has to measure her temperature daily in order to identify the fertile window. And the fertile window is basically a few days before the day of the ovulation and a few days after. And this is the period where she's supposed to avoid intercourse in order to avoid pregnancy. And there are several methods here. There's the standard day method, which is, according to the lay people, is the calendar method. So she needs to avoid intercourse on cycle day 8 and 12, and from day 8 up until day 12, because ovulation usually occurs. We know that textbook, it says like day 14, but that's not usually the case. You have to basically ensure that a few days before and then a few days after. And then you've got the 2-day method. The 2-day method, it depends on evaluating a cervical mucus. And imagine that she has to check her cervical mucus every day. So this requires commitment. And then you've got this symptothermal method, which is basically a combination of all of these. So she has to measure her blood, her basal body temperature, evaluate the cervical mucus, and avoid intercourse, which is complete abstinence during that fertile window. And out of these, this is the most successful if used properly. And then we've got the lactational amenorrhea method, which is basically another method used in the postpartum period if the woman is breastfeeding. So as you can see from this table, on the left side, you can see that this is the pregnancy rates in the perfect use. But you have to realize that a lot of our patients do not have that perfect use. They're usually typical use, if not suboptimal use. So the symptothermal method, if used in the perfect use, it's less than 1% rate. However, pregnancy rates, as you can see here on the right side, are quite high on the typical use and even higher in the suboptimal use. Therefore, this method is not recommended if the woman is trying to strongly avoid getting pregnant. And you can get more information on that through this link. You can basically see it when we share the slides with you later. So as you can see here, if a woman is really trying to avoid pregnancy, this is not the ideal way. Plus that there's a full criteria that she needs to fit, and it requires dedication. And we usually, out of experience, this is not something that we advocate for unless the woman is well educated and well committed. And of course, she has regular cycles. Then we move to the second branch of that diagram, which is the barrier methods. And I did mention that condoms, whether male or female condoms, are the only methods that protects against STIs. And since that they don't have hormones, they don't have the side effects that come in alongside the hormonal methods. They're more than 98% effective if used properly. And it's only for a single time use. They have to be applied prior to intercourse and then discarded thereafter. And we can also inform our clients or patients that there are latex-free options for those that are allergic to latex. And there's an important note here that you have to inform the patient that they're not supposed, if they're going to be using any form of lubricants, that preferably they should be water-based, because oil-based lubricants tend to cause the condom to break. The female condoms is similar to the male condoms, so but their efficacy is less because of the fitting itself. And this is not available in Bahrain. Usually patients would purchase them online or from abroad. But they also protect against STIs. Then we come to the diaphragms and caps. These are not options available in Bahrain again, but like it's important to know about them, that they do exist. As I said, they're non-hormonal, so no side effects. They're 92 to 96% effective if used without mistakes, but it's very important here to advise the patient if they're wishing to use such form, they might purchase it and bring it and ask questions about it, that this is not a disposable form. It's not like a condom. It is something that is reusable up for 2 years. So it's something that basically they can use and then they can clean and then they can store and then use it again. So it has to be applied before intercourse, and it has to be kept in place for a minimum of 6 hours post-coital, and a maximum 48 hours for the latex type, and 30 hours for the latex type and 48 hours for the silicone cap type. And it's very important as well here to inform the lady that in case she has, basically she had an abortion or she has recently delivered or had a fluctuation in her weight, whether weight loss or weight gain, that she will need another fitting because the cap might be, or the diaphragm might be loose, which will basically reduce its efficacy. Now we come to the third aspect of the diagram, and when we're talking about the hormonal type, and if you can recall that we had the combined and then the progesterone only, we are starting with the combined. And the combined, we're going to be speaking about 3 things. We're going to talk about the transdermal patch, we're going to talk about the vaginal ring, and we're going to talk about the combined oral contraceptive pill. All of them, since we say that they are combined, that means that they're composed of estrogen and progesterone, and they will have side effects associated according to that. So basically, they usually will cause the periods to become lighter and less painful, and they can regulate the period. So here it is very important to know that from the history, if we had a lady that has heavy bleedings, menorrhagia, this is a good option because it will cause the period to be lighter. If the woman had dysmenorrhea, which is painful periods, this is a good option as well because it will become less painful. And if the patient has, for example, PCOS, polycystic ovarian cystic disease, it can regulate her period. So basically, نقدر نضرب كذا عصفور بحجر يعني. So this is a good option. It can reduce acne, and we're going to talk a bit about that later because it depends on the combination. the progesterone component. If it had anti-androgenic effect, that means it can reduce the acne, and it can basically help with the mood. If she's a bit depressed or anxious, it might help her with that. We always tend to think that OCPs are associated with mood swings, and the lady is going to be always agitated, but that's not always the case. It depends on the lady. And just because, for example, Latifa's experience with OCP was so-and-so, that doesn't mean that Fatima's experience is going to be the same. There are quite good studies that say that you can basically reduce, for example, premenstrual syndrome, any mood abnormalities like low mood. I'm not saying full-blown depression, but like low mood, dysthymia, anxiety like GAD. This can be improved with the use of combined oral contraceptive pills. So they are, that's like a briefly, عشان we know that whether I'm talking about the patch or about the ring or about the pill, the profile is the same. So if we were to talk about the patch is about 5 to 5 centimeters in diameter. It's light beige in color. It can be basically worn anywhere. And visibility depends where it's located. If the lady wants it to be more discreet, she doesn't want it to be visible, she has to apply it, for example, in the abdomen. And it's very important to know that this patch is a weekly patch. So it's applied for 1 week and then replaced another week. So it changed weekly for 3 weeks and then followed by 1 week, which is, we call it a patch-free week. At the end of the patch-free week, she has to apply another patch accordingly. And because I mentioned this earlier, if she's starting to use it and it's not the first day of her period, she will have to use backup method for at least 7 days. Then we come to the vaginal ring, which is the Nova ring, نفس الشيء profile. So we're not going to touch on that base, but it's very important here to tell the patient that the ring itself has to be basically inserted and kept in place. So unlike the patch is removed weekly. Here, the ring is placed in for 3 weeks. So on day 21, which marks the end of the 3rd week, she has to take the ring out, and then she's going to have a ring-free week. At the end of that week, she'll insert a new ring. Okay, so that's the difference between the patch and the ring. Okay, طبعاً additional contraception when she starts using it for 1 week. The last aspect of the combined hormonal contraception is the pill, the combined pill, which is the COSP. The profile طبعا نفس الشيء. Efficacy more than 99% effective if used without mistakes. So she has to follow the instructions. The pill has to be taken daily at a certain time for 3 weeks, and this is followed by a pill-free period. طبعا هنا I just want to bring your attention to a very important thing. When you're prescribing a combined oral contraceptive pill, it's very important to check the manufacturer instructions, because from one company to the other or one pill to the other, there are some variations. You're going to notice, like most of the boxes we're going to show you in a bit, that if it has 21 tablets, that means that there's only 21 tablets. So these are active pills. They have the estrogen and the progesterone. Whereas sometimes you're going to have a company that says 28 tablets. So 28 tablets, that means that there are active pills and then there's placebo pills. So the placebo pills just promotes the lady to take them so she does not forget her routine of taking the pill every day, but they don't have any active ingredients. So they serve as that week-free associated with the use of the 21 tablet contraceptive method. So in this form, you have to take a very thorough medical and family history. You need to dive into the drug history in order to know whether this is a suitable option for the lady or not, because you're trying to avoid any contraindications. And of course, you have to do a breast examination and a pelvic examination before that as well. With that, we concluded combined. Okay, now we move to our progesterone-only forms, and these are 4. It comes in a pill format, which is the progesterone-only pill. We usually tend to call it mini pill, okay? It contains progesterone only, and since it contains progesterone only, it may cause some irregularities. So the difference between the progesterone only and the combined is that the combined tend to regulate the period, whereas the progesterone only may cause some irregularities in the period. And not only that, it can cause it lighter, but in some circumstances, it might basically stop altogether. And it can cause acne, unlike the other, but again, it depends on the type of progesterone in the formulation. And like the combined oral contraceptive pill, it's very important in order to increase the efficacy. It's more than 99% effective if it's used without mistakes. So the pills have to be taken at a given day, every day. But the difference here that there is no pill-free period. So she's going to be using pills every day for as long as she's using those forms of contraception. And I usually tell my patients that if you tend to forget, or you're going to have issues with compliance, it's very useful to put a reminder, like set a reminder, an alarm on your phone. Nobody's walking nowadays without their phones or their smartwatches. So just put a reminder in, set it for example, 8 a.m. or whenever you wake up and it's suitable for you to take your pill, whether progesterone or the combined, and then take your pill to avoid basically missing that window. And as I mentioned previously in the overview slide, that this is the only form that requires a backup contraceptive method, for example, using condoms for only 48 hours, which is 2 days. And another thing which is it's important to note that this is different than the combined oral contraceptive method, that you don't really need to do a pelvic or breast examination prior to initiating the progesterone-only pill. The second option is the injection. طبعا اللي هو الديبو, we call it ديبو Provera. نفس الشيء طبعا البروفايل, where the side effects are the same, the composition is the same, and it's more than 99% effective. It lasts up to 13 weeks. طبعا it depends on the type. And I've kept here like a small table here. It depends on the type. For example, Depo Provera, the injection is every 12 weeks, whereas, for example, Noristrate, it's every 8 weeks. The Sayana every 13 weeks. And there are variations when it comes to, like, even when you go, like, and compare different guidelines, for example, in the BNF, they would tell you that you can basically extend that period using the Depo Provera even up to 14 weeks. But there is no consensus when it comes to that. But usually we tell the lady, just get a injection, put a reminder, come into the office every 12 weeks and get the injection basically delivered. It's important to know here as well that when you're counseling a lady to use the injection, she says that I'm a forgetful type, I don't want to use the pill, I'm going to go for the injection. But you have to tell her that there's a rebound infertility period. What does that mean? That means, like, if she decides to get pregnant and she stops taking the injection, then she probably might have difficulty getting pregnant for maybe up to 1 year after stopping the injection. So she has to be aware of that. So this is something that we usually inform them when we're doing the counseling session. So she doesn't freak out that she lost her fertility after stopping the injection. Then the third type, which is the implant or the Implanon. And as I mentioned, it's very thrilling that this is an option that our family physicians here in Bahrain are being trained to do. And that hopefully in the near future, it's going to be available at the health centers. حالة اللي هو intrauterine device, الcopper, أساساً it can be inserted or administered to our population. and a side effect profile is the same, and it's more than 99% effective. Usually it necessitates like a small incision in the triceps area in the non-dominant hand. So if she's a righty, you're going to be inserting it on the left side and vice versa. So this requires usually an appointment with the doctor who is trained to insert the implant on, and she requires a week of backup method. Finally, which is the hormonal coil or the hormonal intrauterine device or intrauterine delivery system اللي هو المارينا. This is low dose progesterone, and as I mentioned earlier, it makes the period lighter. So if the lady has menorrhagia or a lady has dysmenorrhea, this would be a good option. فيعني we can give her contraception and we can treat her heavy periods or treat her dysmenorrhea. It can cause acne. And here the thing is, we have to inform, if you go to different guidelines, they're going to tell you that this lasts for example, 5 years. Other guidelines is going to say 7 years. The others would be 8. But usually we say from 5 to 8 years. Usually the lower range is the efficacy of it treating menorrhagia. And up until 8 years, that's where it's effective for preventing pregnancy. So let's say if it was inserted specifically for menorrhagia, after the 5th year, it's no longer going to be viable. She will need to replace it. But if it was for preventing pregnancy, she can use it up to 8 years. But in our practice, we usually tell them it needs to be changed after 5 years. بهاي خلصنا a full chunk. So we finished the natural, we finished the barrier method, we finished the hormonal methods, so kind of combined, or progesterone only. We come to the other methods, and the other methods اللي هو عندنا copper, which is available in Bahrain as well, in health centers. But this is basically a T-shaped plastic اللي هو device, وفي اللي هو coil of copper. الطريقة الميكانيزم of action ما له علاقة بالovulation والthinning مال الاندومتريوم نفس اللي هو الهرمونال types. This causes اللي هو basically local inflammation and prevents the sperm. It has a toxic effect على السperm. ويسوي اللي هو basically inflammation, making it impermeable and difficult for implantation. طبعا this can last up to 10 years. بس احنا بعد in practice, this is not what we do. We tell the lady it's between 3 to 5 years. And the only reason for that, and it is noticed that most of the women that uses the copper have recurrent vaginitis, يعني recurrent local infections. Therefore ما نحب إن basically it lasts for longer period of time. So it usually gets replaced. And this is not a good option for a woman that has menorrhagia, okay? لأن if you insert it, it's going to cause more heavy bleeding. And that's how we are tailoring. You have to take a proper history and then discuss with your patients her options. So في أشياء من أساس is not a proper fit for the lady, because you know from the medical history that this is not a good option. But I have to discuss with her why it is not a good option, because most of our patients would come, but my friend is taking this and my neighbor is taking this and I want it. And you have to tell her why is it not a proper thing for her. طبعا I did mention this earlier. This is the only method that does not require backup contraception, okay? Once fitted. So the second section, or this section basically, is the surgical options. The surgical options, these are usually done in secondary care, but we can counsel our patients that these are options. But and bear in mind that these options, we do not prefer to give it as an option أساساً for any male or female, depending on the procedure, that are under 30 years of age. Okay, and that don't have kids, because they might change their minds and they want more kids. So you have to make sure that if you offer this or discuss this with the patient, they have to be 100% sure that their family is complete. Yani I will not change my mind, because they are permanent. They are very difficult to reverse. Okay. وطبعا it is not 100%. ما في شيء 100%. يعني ما في شيء 100% except abstinence. فإحنا نقول لهم عادة this is more than 99% effective or 99.9%. يبقى اللي هو 0.1% that pregnancy might occur. It is important to inform the patients here that they will need to consult with several healthcare providers. It might start with you as a family physician, but later on, she will have to go, for example, to the gynecologist and the anesthetist, or several consultations to see if she is fit or not when it comes to tubal ligation. And this will be effective once she gets her next period after the procedure. فإحنا دايما نقول okay, you're going to do the tubal ligation today, wait until you get your next period, and then you can have unprotected sexual intercourse. Vasectomy is the same thing. It will require multiple consultations. So it starts with us telling them what it is, explaining to them whether this is a feasible option or not, and then sending them off to the gynecologist with their wife to discuss other options, or directly to the urology and the anesthesia to do the procedure. The difference between here, we say this, that vasectomy is a daycare procedure that is done under local anesthesia, whereas the tubal ligation is a major surgery that requires general anesthesia and admission to the hospital. And it is successful. How do we know that the vasectomy is successful? Between the week 8 to 12, they have to have basically precautions. And at usually week 12, that's where they do a semen analysis. A semen analysis has to show azoospermia, which is basically, it has to be semen-free. And that's when we know that it's successful, and then they can have unprotected sexual intercourse without a backup method. Usually, and most of the practices, they will require 2 samples, not only 1. آخر شيء بنتكلم بس سريع على emergency contraception. طبعاً up until lately, high option was not available in Bahrain, but it was available in Saudi and Emirates. And now recently, we got that option in Bahrain as well. So we have, it either comes as a morning after pill, which is a progesterone only pill. It doesn't contain estrogen, it's only progesterone. And then you have the copper coil. The difference between the two is that the copper coil can be fitted up to 5 days. هاي النقطة الأولى. فالwindow is wide. النقطة الثانية, the second point is that it can protect against pregnancy even after ovulation. The pills, there's no point of using them, or they are not effective if ovulation occurs. Whereas the copper coil is effective even if the ovulation has occurred, because it prevents implantation, it prevents pregnancy from happening. That's why we tend to tell them, if you are already pregnant and you insert the coil, you're not going to abort. It's not going to cause an abortion in a pregnancy that exists. So it only prevents it. It doesn't terminate it. As for the morning after pill, I said it's progesterone. في 2 types. We have levonorgestrel. This window up until 4 days. بس the sooner used after unprotected sexual intercourse, the better. So usually the time frame 72 hours, which is 3 days, but we can stretch it up until 4 days. And then we've got the Ella1, which is the uliprastol. This is similar to the copper up to 5 days. Okay. And it is very important to tell this to the patient, that the effectiveness of the morning after pill may be reduced with the BMI. كل ما كان the lady has a high BMI, this is less likely to work. طبعا هاي I just put this in على أساس to show you إن the left side اللي هو البوستينور والنافالا، هاي اللي هو الليفينورجسترال اللي هي الويندو 4 days، والعندنا اللي هو الإلا 1 والأسنك. طبعا هاي الأسنك recently being here in Bahrain. This is only 1 pill. البوستينور والنافالا شو اسمه، هاي الويندو 4 days، الإلا 1 والأسنك الويندو is 5 days post coital. Okay. That was quite comprehensive. فحين خلينا نشوف إذا كنتم مركزين معايا شوي. So how to choose. احنا عرفنا الحين إن I have this diagram either in my head or I've printed it and I put it in my clinic عشان whenever I have a patient with me, I'll show her options and go and discuss the different branches of that diagram. الجواب tailor contraception method to what your patient needs. So personalization, tailoring family planning to individual needs. So it's very important to tell her what suits others does not suit you. فالأشياء اللي لازم.
For the interruption, دكتورة إيمان, you have 5 minutes إن شاء الله.
Okay, okay, so I'm just gonna wrap this here and we're gonna keep the cases if there's يعني ما في مجال بنطوف في الكيسات, okay? So أهم شيء إنه لازم تعرفون اللي هو الcompliance مالها very important, الage, الside effect profile, الcomorbidities, use of other medications or herbal remedies, irreversibility يعني how soon she wants to get pregnant, وطبعاً الcost is very important. Remember this diagram. هذين اللي هو الoptions اللي موجودة يعني this is a very يعني nice يعني I'm not here an advocate for Al-Nahdi pharmacy, but if you go to their website, you're gonna not only see the different options available of contraception ويا the prices, but under each they will tell you the side effect, the contraindication, the way of using it. Okay. I'm just gonna go through some of the cases. المفروض إنه يعطوكم poll until يعني you guys stop me لأن this is the end of my presentation. So let's just take a few cases until I'm stopped. So case 1 is a 35-year-old lady had intercourse with her husband before traveling for a business trip. She remembered that she forgot to take her OCP, which is Guinera. And it's more than 12 hours overdue. This is her 3rd week of use, and she has been very compliant up until today. What is the answer? Should she take all the remaining pills at once and use a backup method? Should she take 1 pill as soon as possible, resume rest regularly, take 1 pill, resume rest regularly, and backup method, or use emergency contraception? يلا جماعة عشان يصير عندنا مجال. What do you guys think? So we have 45% said take 1 pill and resume rest regularly. Yes, that's the right question. Answer, I mean. طبعاً ليش? Next slide tells us ليش. This is very comprehensive. I'm not going to go through it. This is for you. You can basically go through. There are key things here. أولاً إن she's compliant. Number 2, she's been using it correctly. Number 3, she's in her 3rd week. So basically, she goes under this branch where she doesn't need to do anything, okay? وطبعاً اللي هو very important إن التايم فريم إنه more than 12 hours. Second question, 28-year-old lady on Cerazette, which is a pop for contraception. She is breastfeeding. She usually takes her pill at 7 a.m. However, today she woke up late at 11 a.m. and she stayed up all night taking care of her baby. What should she do now? Continue as normal, take the missed pill as soon as possible, and resume the rest regularly. Take the missed pill, resume regularly, use a backup method for 2 days, or use emergency contraception. في key things هني في عندنا she's breastfeeding that's why she's using السرزت وبعدين هي she's using it at 7 أخذتها 11 so this is more than 3 hours. Let's see the answers. So we have 43% take her missed pill as soon as possible and resume the rest regularly. That's not the answer. Okay, so it's continue as normal, and I'm going to tell you why. This was a tricky question. The answer is basically here. Most of the progesterone-only pill, the window is 3 hours, like the Microlet, but she's on Cerazette. Cerazette, the window up to 12 hours. So that's the only key thing here. Because she is not within the 3 hours, but she's less than 12 hours, so she doesn't need to do the same. طبعاً في نوعية اللي هي slender up to 1 day as well. Next question. Mariam came to your clinic with a 2-day history of epigastric pain with nausea and a single episode of vomiting. You diagnosed her with acute gastritis. She takes Cerazette for contraception. She vomited 3 minutes after she took her pill today. What advice will you give her? Do nothing, as today's pill she already took it. Take another pill as soon as possible to compensate and continue as usual. Take 2 to 3 pills to compensate, then continue use emergency contraception. What do you think? She took it and she vomited نص ساعة بعد ما أخذتها. See the answers. So 72 said take another pill as soon as possible to compensate. صح. This is right. So these are the different factors that impact the effectiveness. So if they didn't take it within the designated window, vomiting within 2 hours, severe diarrhea for more than 1 day, and any drugs that can basically reduce the efficacy, such as anti-epileptics, anti-TB medications, HIV medications, and certain antibiotics. لازم طبعا تاخذ اللي هو additional contraception for 48 hours if that happens. Fourth case, Sarah is a 38-year-old lady who came to your office seeking contraception as she has recently been married but would like to postpone getting pregnant. She has smoked more than 20 cigarettes per day for the past 10 years. Which contraceptive method should she refrain from using? يعني she should not be using in her case. Condoms, copper, IUCD, Mirena, or combined oral contraceptive pill. %78 combined. صح. So hi طبعا, this is very important for you to know the contraindication. This is like a very comprehensive list اللي هي مالت WHO medical eligibility criteria. احنا طبعا صعب علينا ان نحفظها بس لازم you remind at least الاشياء اللي refrain category 4 category 3 هاي لازم نعرفها. طبعا في اشياء that makes our life easy. You might have seen this, which is اللي هو المك wheel or you can basically now download it عن طريق اللي هو حق الاندرويد والابل واللينك بعد موجوده في السلايدز على اساس انه it helps you to see whether the patient fits or not. Fifth case, Latifa has been annoyed about her skin appearance and she has developed acne, which she is attributing to her current contraception. Which contraception method is she less likely to be on? Less likely, جماعة. Cerazette, Depo-Provera, Mirena, or Yasmin? %55 said Yasmin. صح. So Yasmin is a combined oral contraceptive pill, so it's estrogen and progesterone. والشيء المهم اللي تعرفونه ان البروجسترون اللي هني it has an anti-androgenic effect. Okay? I'm done.
Thank you, Dr. Eman, for
Welcome.
the outstanding presentation. It was very, it covered the contraception from a practical point, and we would like to appreciate this presentation. Thank you very much.
Thank you very much. I'm just going to take this opportunity to thank you once again. Inshallah, all the content you guys are going to have it. There's 2 more cases with summary of everything بيكون at the end of the presentation. محطوط لكم في اللي هو table everything that I've يعني discussed and even more for your review, and good luck. Thank you very much.